on this computer. There we go. So we're going to talk about chronic pain now. So when a patient comes in to see you guys, right? The patient comes in and talks to you, and what do they want to know? Well, there's a bunch of things they want to know. Yeah, right? Believe it or not, a lot of the legitimate patients that come in to see you, they want to know what's wrong with them. And sometimes that could be so many things, right? How long will it take to treat, right? Did any of you ever hear that, those that go in the clinic? How long is it going to be till I get better? Right? And they expect us to say, well, you have 5 visits and man, magically everything's gone. It may not be that way. The good patients ask, what can I do to make it better? Because those are the patients that legit want to get better, right? But the other ones look at you and go, yeah, returns for it. A lot of them look at you and go, what are you going to do for me, right? They tune into one radio station, WIIFM. What's in it for me, right? Nowadays, does my insurance cover you, right? Because physical therapy reimbursement is getting worse and worse in this country. And if Ted Cruz has his way, he wants to decouple physical therapy from health insurance and make it an ancillary service like dental services are, where if you wanted to have physical therapy insurance, you'll have to pay for your own rehabilitation services, right? And I don't know how many of you guys know about this, but people that when they have the decoupled dental away from their medical plan, even the dental plan may only cost $1 a month. Guess what most people do? They don't take it. Yeah, they skip out on that $1 a month. Like that $12 a year is going to make them that much richer, right? But they don't see that. They just see that that's an extra $1 a month. You know, that $1 a month does add up. If you ever get a dental plan, just take it. Guarantee you one time you're going to need it and it'll pay for itself. Will I miss any family obligations or work because of this, right? And especially in this area, that's a huge question. Because the majority of people that live in this area don't necessarily live below the poverty threshold, but they're skirting pretty close to it, right? So they miss one day of work. That can mean homelessness to them, right? That's why so many people are so terrified right now. You know, it's funny when you see all the people protesting, opening up the government, right? How many of those people do you think that are protesting, opening up the government, opening everything back up right now, are in danger of losing their jobs? I think it's the other way around, Alex. I really don't think a lot of those people that are protesting are in danger at all. And the ones that I see, at least, and the ones that I encountered when I was at I saw outside the hospital, were people that were complaining because they can't go get their hair cut. They can't get their nails done. They're not saying that they want to go back to work. They're saying that they want other people to go back to work so they can get what they want. Right now, are there some people that need to get back to work? Yeah, absolutely. Right? They miss the necessities, but Flobies work. Oh, well, just listen. If you get a chance, Alex, listen to some of the interviews of these people. First of all, it just blows your mind when they say these things, right? And I've said this before, when they talk about essential workers, really need to change that word. It's not essential. It's expendable. We are expendable workers. That's really, truthfully, even healthcare, we're expendable workers. They're figuring that if we die, that we can be replaced. Maybe not. But yeah, I mean, are there people that are worried about getting back to their jobs? There are, but you know what? Most of the people that are really in that category where they want to get back to work, they need to get back to work, they're also smart enough to understand that if I go back to work, Abuela is going to die. So I'm doing this to protect my family. Right? They know intrinsically that, yes, this is going to be a hardship right now, but they're not doing it for themselves. They're doing it for the greater good of people, right? How much will this cost? That's a huge thing I hear, right? And this is, again, I talked about this multiple times throughout your program, this is an area where we fall short as physical therapists and physical therapy assistants. We don't have the ability to package this to patients and go, this is how much it's going to cost you. And if you do this and follow with me for so long, this is how much I'm going to give you in discounts. It's amazing how chiropractors do that. I don't know why we are not good at that, but we just aren't. We have no skill in marketing whatsoever. PTs that do have some really successful practices. right? But that's what patients are looking at. Now, there's some other questions they may ask in there too, but that's kind of what they want to know. There we go. So let's look at a patient that's got low back pain with radiculopathy, right? So what's wrong with this patient? Patient's got low back pain with radiculopathy. What's wrong with them? Toss some ideas out there. Okay, probably structure, right? They got radiating pain, good. Yeah, probably some nerve what? Impingement? What nerve's probably impinged? 99% of the time. Yeah, sciatic or the roots of the sciatic, right? Good. So where's their pain distribution going? Down the back of the leg, right? The back side of that leg and going distal out to the big toe even, right? Not typically in the front of the leg, right? So what muscles might they have wasting in? Maybe some hamstrings, good. Right, gastroc, right? All those back kind of muscles. Maybe even a little bit of glute, because glute gets some fibers from. Piriformis is another big one, good, right? So your typical patient that comes in with low back, so what is the term for low back pain with radiculopathy typically called? What's the short form of that? Lumbago, right? Or lumbalgia, whichever one you want to use, either of those works, right? That's the typical term you're going to see for it. It just means they have back pain and it's going somewhere else, right? They got back pain. How long is it going to take to treat this patient? Patient asks you that. What do you say? Now, I know I'm asking you guys to do some PT thinking here, but I want you guys to put on your smart hats here. What do you tell patient? How long is this going to take? Not this treatment. Everyone's different. Good. Depends on that's a great answer right there. It depends how much work you put in, right? But then the patient's going, oh, come on. I'm going to be the hardest worker in the world. How long is it going to take for me to get better? They're lying. House says it very quaintly. Everybody lies. I was just watching a house marathon last night, so. Right. So does anyone know what we typically say for a low back patient, what our goal is? Till centralization, good, right? But we have to give the insurance some kind of you have to give some sort of a time period. What do you think we normally give them? A couple of months, good. You usually say 6 to 8 weeks. In 6 to 8 weeks, we'll kind of reassess the whole situation, right? 12 visits maybe, right, depending upon what their insurance is, right? But we'll say about 6 to 8 weeks. It's going to take, and the more upfront, if they get it right. But the thing is, if we are upfront with them and tell them, hey, look, this isn't going to get better in a week. It's going to take us a couple weeks to get you there. You need to hang in with us. Do you think we might have better compliance? Yeah, it does show that we have better compliance when we are upfront with them. But why do you think we kind of avoid telling them that 6 to 8 week period? There's a couple reasons. Yeah, people are impatient, right? You hear 6 to 8 weeks are done, so you'll get 10% of them that are out. Some will get frustrated, good. But what about those people that they hit that 8 weeks and they're not better? You said 6 to 8 weeks, and I know what I said was 6 to 8 weeks, and we'll reassess where you are. But they heard I'm cured, right? So this kind of all works into itself. What can the patient do to make themselves better? What are they able to do? HEP is like automatic HEP. Good, right? Take their therapy into their own hands. Exactly. Not only HEP, but nutrition, right? And rest and changing their bad habits that led to it and all that. It's a lifestyle change. You've heard that before about diets, right? I always hate the term diet because when you go on a diet, it's a temporary thing, right? You think about that when anyone's ever gone on a diet, do they ever stay on that diet? Not typically, right? If you hear somebody that's, I'm gonna go on the juice cleanse diet. You're always on it, exactly, right? Diet is what you eat or drink in my case, right? But a lifestyle change is different, right? That's where they've got to go, okay, I need to change some of my bad habits. I can look at myself and find 5 or 6 bad habits that I have in my diet that could make a drastic change in the way I am. I'm just too stubborn at this point, So what are you going to do to make them better? Well, you're going to encourage them, right? You're going to try to get them going. You're going to try to come up with the best plan. But the best laid plans of mice and men have a tendency to fail. So the main thing for you guys is you have to be flexible. Insurance. For a lumbalgia patient, what do you think a patient's average out-of-pocket is going to be? Let's say they've met their deductible. Right, so let's say they met their deductible for the year. So they've got 6 to 8 weeks of therapy. What do you think average is in the United States? What do you think average physical therapy copay is right now? Let's go that way. 55. Yeah, it's anywhere from 10 to 75, right? Depends on your insurance. 55 is the average right now, right? So how often is the low back patient going to come to therapy? In a week. 2 to 3, right? Hopefully we can get, if we get 3 times a week, man, we can actually make a difference in that patient, right? Well, let's just say they come 2 times a week, right? So they have $110 per week in copays. And let's say they go for that whole 8-week time. That's $880. $880 a lot to you guys? Yeah, plus other doctors' visits, right? Because they're probably going to have to get reviews and everything else, right? Maybe they have to get some x-rays. And that's saying that your insurance covers it. What if you're a Medicare patient and you've already used up your therapy cap? Now you're SOL. Right? Everything's cash. Straight out of pocket. Yep. Or maybe, you know, you're a TRICARE patient and you really want to see this therapist because they're a specialized person in low back pain, but they don't take TRICARE. Yeah, lose your DCM, right? So they're going to have to pay out of pocket. There's all kinds of things that can come into play with this insurance thing. Insurances are mean to patients. They just are, right? Do you think patients going to miss some family obligations, some work for from their back pain? What do you think? Yeah. What do you think is going to be more detrimental to them? Missing family obligations or missing work? What do you think they'll say is more? Okay. I see work, I see family. So it depends. It all depends on where you are in that SES, the socioeconomic status, right? If you're low SES, work is your priority. But if you're in that kind of you know, middle income to maybe even low upper middle income range, the family is more important to you at that point because you've got enough, maybe some nice vacation that can cover you for a couple of days. You're not really missing out on that much. Maybe your boss is chewing you out, but you really didn't like that job anyway. And blah, 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 right? So family's a little bit more important. So it really depends on your SES. For those low SES patients, low socioeconomic status, that work means their kids getting food or not getting food, right? Them having a place to live or going out and living under like a bridge on the alphabet streets. It's terrifying, right? So we have the costs. We already talked about the insurance costs. What other costs might they encounter? We talked, other than doctors' bills, what other kind of costs are they going to encounter during this therapy treatment, 6 to 8 weeks? Transportation, good, right? What if they don't have a car? Now they got to pay Uber, right? What about medications? Maybe, right? If they're getting anti-inflammatories or anything like that, right? Any equipment, yeah, and a lot of that stuff isn't covered, right? A lot of the little stuff, especially if we're like, oh, you know, this Theracane can really help you out. Theracanes are wonderful little torture devices, right? But they really like that Theracane. That's probably not going to be covered by their insurance, right? The hamstring straps for stretching out the hamstrings. Those mostly aren't covered by their insurances, right? I always think we're missing, yeah, you could, right, could use Talgena, right? But let's face it, come on. We're a consumer society, right? They see that cool little toy that we have in the gym, right? They use it but they see that cool little toy we have in the gym and they want one, right? Oh, hopefully, I'm glad that you do. That's right. But they're still thinking about it. I guarantee I've had patients I told them they'll work some money, and the next week they're like, I bought one of those green strap thingies. And you're like, oh, son of a. Why? Right? I think we miss out on that one, right? Because I think we could market some of them, get some of those with the clinic's name on it, right? And then, you know, use them as loss leaders. What I mean by loss leader is, you know, give them to it at or around cost. So, you know, if they cost $15 to make, sell them to the patient for $12 because you're selling them something with your brand on it, and it's more likely to get you more brand recognition. That's where we kind of fall short. There's a lot of brand recognition we could do. Well, through this whole thing, what's your patient's name? I've had this happen before. Had a patient being seen by a PT and a PTA team, and I took over on PRN for like a week for the PTA. And I asked the PTA, you know, well, what's the patient's name? And the PTA is like, it's like Dan or Dave or Jack or Sandy. Oh no, they're low back, they're the lumbalgia, right? They've been seeing them for 4 weeks and they don't know their name, right? One of the first things I try to assess, right, talk to your patients, right? It's not a personal experience if they don't know your name, right? One of the things I try to stress when I first encounter a patient is, you know, I'll tell them what my name is, but then I'll say, what would you like me to refer you as? Do you want me to call you Mr. Smith or Mrs. Smith? Do you want me to call you John or James? Because I hate when people call me Mr. McKeever, even though I have to have that for PIMA. I really hate that. I just despise it. It annoys the crap out of me. Mr. McKeever is my students in the martial arts. Those are the ones that call me Mr. McKeever. And I always joke, Mr. McKeever was my dad. And I've already figured out I don't have the best relationship with my dad. So it's not always the best interest, right? I tell them what they can call me. And it's amazing because how many PTs do you know that go around describing, calling themselves, well, I'm Dr. So-and-so in the clinic. Do a lot of them do it? Barely any, right? Who is it usually that does it? Does anyone know? It's usually new grads. Yeah, right? Because they haven't become jaded yet. They haven't been beaten down by society. At that point, they're just like, call me Mud. Right? And they haven't had a DO challenge them yet. Right? They haven't had an MD challenge them yet. Yeah, I mean, I'm in the military I was used to being called McKeever. I don't even have a first name. Or LT, right? One of those two. You know, martial arts, I do go by Mr. McKeever when I'm training, right? But even when I played football, it was McKeever. We didn't use their first names. I used to talk to Dr. Cham about this a lot, that, you know, in the locker rooms, even when you're treating, no one has first name in the locker rooms. And usually the names they call you aren't very pleasant. But yeah, those of you that are in clinics, do you know some PTs and PTAs that don't know their patients' names? Yeah, Gunny. Exactly. Gunny's a term of endearment. All right. So let's look at a low back patient here. Let's look at a bad person. Let's see how this patient does. So 3+ years of chronic lumbalgia. They've got a fibromyalgia diagnosis. They've seen 12 healthcare professionals or providers in the last 2 years. Pain continues to spread, but it comes and goes. They've got insomnia. They have less than 20 minutes of standing tolerance and less than 60 minutes of seated tolerance. You know, you hand them the pain screens, and what does our pain screens look like, do you think? They're just colored in. They just color the whole body in. There's where my pain is, right? And the patient's unable to continue. So here's the thing. Patient says, I'm unable to continue work, and I'm not able to go to Pilates and yoga. So what's that clue you into there? That's a big key. Why do you think that's a big key? Yes, they were active, right? So at some point in the last 3 or 4 years, something changed that made them inactive. Do you think they probably feel bad about being inactive? I bet they do. I bet they're stuck in that cycle again, right? And if we can get them back out of that cycle and back to that yoga, it's amazing how much that will resolve itself, right? This look like your typical patient? This looks pretty common, right? Motionless motion, exactly. If this looks exactly like a patient you're gonna see an outpatient. You know, the only thing that's missing here is polypharmy, where they've got a prescription list mile long, right? The fibromyalgia diagnosis, right there. This person may be, right? This patient wasn't, I can tell you that. But the fibromyalgia diagnosis, in this patient, I'll say again, I often use a lot of my real-time patients for this. Fibromyalgia diagnosis was really bullcrap for this patient. Because the patient went and saw a pain doctor. The pain doctor said, you must have fibromyalgia. Right. And so you've got fibromyalgia. So now the patient's in their head looking on WebMD or Dr. Google and looking at going, oh yeah, I have that. Oh yeah, I have that. Oh my God, that makes so much more sense now. And now they've internalized fibromyalgia. Right? When before they were just low back pain. It's so crazy the way this happens, right? What does the 12 healthcare providers in 2 years tell you? Yeah, now we got to fix both, right? What's that 12 healthcare providers tell you? Could tell you a couple different things. Could tell you something good and could tell you something bad, right? So the good side is they're not finding the cause of their problem, so they keep trying to find somebody else, right? To get to the root cause of the problem. What could be the bad problem? What could they be doing? Yeah, doctor shopping, right, for medication. Exactly. So that's one of those we got to kind of look and go, okay, who are they going to see, right? If I look at those 12 healthcare professionals and 8 of them are pain doctors, right? Then I'm starting to get a little worried, right? But if I look and 7 out of the 12 are PTs, that's going to tell you how much faith does that patient have in PT? 0, right? Because you're saying the same thing that the last PTs have said to them, right? So let's look at it from a different outlook. How about a pain neuroscience outlook? We're going to talk more about this as we go on. So when a patient says, usually not, Alex, honestly, unless you're lucky, you can request PT records from other clinics, but they do not have to provide them for you. Your best bet, if you have that, where you know that they've gone to other PT clinics, is send the patient for their records to that clinic and then have them bring the records. Because it's not likely that ATI is going to send over to, Select. Now the hospitals, most times hospitals are pretty fair about sharing stuff because they're a little different billing, right? But you leave ATI, it costs ATI money. They're not going to give Select all the documents so that Select can make money off that patient, even if it's the right idea. And I'm not picking on ATI or Select there. It could be the other way around. Select's not going to give ATI the records either, right? Or if they do, it's in such a messed up, Or if they do, it's in such a messed up format that it's useless anyway, right? They'll print off some weird format that's like comma separated values from their e-healthcare record, and it doesn't make any sense anyway. This patient says, what's wrong with me? What really they're saying, it does have to be better, right? We have to, that's one of the things I was amazed with in Denmark is the centralized healthcare system means I go to any doc, they can pull every single record I've ever had. It's amazing. But patient says, what's wrong with me? What they're really trying to say is, why do I hurt? Right? They don't legitimately think something's necessarily wrong with them, but because they hurt, they think something's wrong with them, right? How long will it take to treat me? The main thing is they're looking at, will I get better? Will it ever get better? Is there any hope? Right? They're looking for that little glimmer of hope in you. And now it's 4:30 on a Friday afternoon. You've already saw 10 patients. and your front desk guys or gals come back to you, and I know you're getting off at 5 o'clock, but we slipped Mrs. Smith in because she can't get in tomorrow for her appointment. I hope that doesn't bother you, but she's out in the lobby waiting on you right now. Has anyone ever seen that happen? Yeah, triggered immediately, right? Your attitude, and it's not, and your attitude is not towards Mrs. Smith, although Mrs. Smith is now the focal point of that attitude, right? It's more towards the front desk people, right? But she is now the target of it. What do you think she's going to get from you vibe-wise when you go treat her? You're done, right? I don't care about you, lady. You may even care, but you're so burnt out by that point, and they've already thrown 5 other people on your schedule for the day, even though you thought that you had time to do notes. And you know that by now taking Mrs. Smith, you're going to be there till 7 o'clock doing your documentation. You were hoping to get done in that last half hour, so that maybe you could go out and get margaritas with the rest of the group. But oh no, they get to go to margaritas, and you've got to sit here and do documentation. These are the things you're going to deal with in a real clinic, right? And the patients do really want to know what they can do to make it better. They honestly do. It's amazing how many of them do, and if they don't, there's other reasons for it. Then what are you going to do to make it better? They really want to know how are you different, right? And sometimes that different can just be in the way you present yourself. I consider myself pretty different. Just saying. I don't present myself like the average person. And I often wonder if that's why I get good results. I spent so many years in corporate that I just don't care anymore. What are they going to do? Fire me? Well, go to the next job. Right? It's just I'm caring more about the patient. That's why I love working with my kids, because I'm not really held to, all these hard standards. I have to take the kids and make them better. Right? That's amazing to me, but I have a vested interest in making them better. Now, let's think about this for a second, because this is coming down the pike. Let's say your reimbursement is now tied to the patient getting better. Should you care more about your patients then? Yeah, right? I know that PTs and PTAs are all against this. They hate this fee-for-service idea. If you ask anyone, it's going to ruin physical therapy and blah, 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 blah. What they're literally saying is, I'm scared of change. I'm already overworked, and this is going to put more on me having to care about my patient. Or the other side is, I don't understand it. Because it is complicated, right? But in every other country that's out there, your reimbursement, your salary is based on how your patients do. It's almost like sales, right? Has any of you worked in sales before? Like commission type sales? Right? I know that at least Justin's done Primerica, so, right? If you're not out there, getting the best stuff for your clients and getting money off them, you're not making money, right? And that's the thing with sales is, a lot of times, the harder you work, the more money you can make, to the point that you can literally melt yourself down, right? But is that totally bad to think that we could do that in physical therapy, that, we're going to get vested interest in them getting better? Is it wrong to think that doctors should have their reimbursement tied to their post-surgical infection rates? Right? I don't think those are wrong things. It's going to be hard. Everyone's going to have to adapt to it. And the patient mills are going to lose money. They're going to do one of two things. They're going to lose money and adapt, or they're going to take more patients to make up for it. Those are the only two things they can do. Right? The patient satisfaction scores are always interesting to read on some of those patient mills, right? So what kind of treatments can we do with this blood pathogen patient? What do you think here? How many of these, what would you say we could do with this patient out of this list here? Okay, traction. Jen's like, let's try traction. Great. Why is your idea for traction? What clues you to maybe do traction with this patient? What's screaming out, Jenna, that made you say traction right off the bat? Radicular pain, exactly, right? You're looking at it, you're seeing a duck, and you're saying, well, if it's a duck, let's strap it into the pool, right? And see if it gets better. Great, right? Stim, okay, good. Stim wouldn't be bad. Oh, I don't care about that. It's radical pain, man. What about spine mobs? Stretch, okay, good, right? So that's going to come under what category there? Stretching. Stretching and PROM is going to fall under what technical category out of all that? Yeah, manual, right? And more likely, it's literally, that's more of the spinal stabilization. It really is, even though it's not necessarily, that's where it kind of falls when we're looking at these patients, right? Core stave, right? What about spine mobs? Do you think it'd work for this patient? Okay, I got one yes. Why? Maybe. There, yeah. That's the better answer. Honestly, with radicular pain, probably not going to try mobs. Because depending on how inflamed that or where that disc is, if you mob it wrong, now you push that disc even further. I think I would go traction first if I was the PT here, right? Directional bias training, right? You learn a little bit about that, right? You know, going in the direction that moves the disc back the way it is. There's definite positives there, right? How many of you would do kind of a combination of all of this? What do you think? Okay, good. It's not bad. But what's the problem with doing a combination of all of this? If you do a little bit of everything, you don't know what worked, right? Right, so this is why we got to be careful. We got to pick maybe one or two out of these and go with that and see if they get better. If they don't get better, maybe drop one, try something else. This is where we've gotten better at this, but when I came up through, it was literally, so patient came in with lumbalgia, they got all 5 of these. There's 5, right? 1, 2, 3, 4, 5, yeah. They got all 5 of them in one session, right? It was a shotgun approach, and they would come in for therapy for an hour. And they get all these. Right? Yeah, first day, exactly, right? That makes sense. Because we're just like, well, let's see, this all is gonna work. And then the patient's getting worse. They used to, right? They used to come back because they used to get, I mean, therapy used to be really well reimbursed that they didn't have to pay much for it, so they didn't care. But yeah, I mean, we've learned from now that, you know, we can't necessarily, how long do you try till you try something else? I don't know. I mean, if I'm not getting a result in 2 weeks, probably trying something else. You know, 4 visits. If I'm not getting something out of it. But again, the problem is we've learned when I talk to you guys about traction, right? You know that those first couple of visits, what's going to happen to their pain on traction? It's typically going to do what? Get worse. Yeah, right? You got to get them over that hump. Tell them, okay, I know it's going to get bad. Right? Especially when you take them off that traction because they're going to get that boom, that rebound effect. Right? No, it's going to get worse. Just let's go through it, right? Explain it exactly. Being upfront with your patient does a lot of things. It's amazing how much it does with the patient, all right? How about digging deep with your patient? What's your patient know about their back pain? Right? Does the patient even want to know about their back pain? Because some people don't. Some people just don't care. They just want to get better. Can you educate your patient on the back pain? You know, how afraid is the patient of learning the true cause of their back pain? Could there be some scary things? Take up spinal? Yeah, could. Okay, we're going to talk about that in a second, Jen, actually. That's a really good comment. That's one of the things we do, right? You break up the spine model with the little orange bulging disc. This is what your back looks like. And this little disc is pushing over here, and it's pushing into these little orange nerves hanging, or the yellow nerves hanging out the spine, right? You've seen it, right? It is. But when a patient sees that, what do they see? They see a bright orange disc bulging out the side of their disc or their spine that's huge, and they're going, Ermiger. They're terrified, right? So at that point, they're like, I don't need to know anymore. I'm done. No. Right? Do you think clinicians are ever afraid of learning what's wrong with their patient? What do you think? I know patients are afraid of learning, but what about us? Do you think we could be afraid too? Yeah, some are, right? Because, you know, once it starts walking and quacking, and we look at the flippers, and we're looking at the feathers, and man, that bill looks awful familiar, and we're going, man, this looks like a duck. But I really hope it's not a duck, because that means that nothing I'm going to do is going to help them. Right? So maybe it's a goose. Oh, it's not a goose. Okay. Well, maybe it's a swan. Oh, it's not a swan. Okay. Maybe it's a terrapin. Right? In reality, it's a duck the whole time, because we don't want to find out that it's a duck, because it's a duck we can't fix. Right? So sometimes I think we're afraid of learning it too. And then, are you confident about your skills to treat a patient? Right now, you guys aren't the most confident. Right? I mean, some of you are. Some of you feel like you're ready to rock and roll. But if you were my student, and I tossed you this patient's case file, how many of you guys would honestly be a little worried about treating the patient? Anyone? Okay, good. Honest. That's honest. Great. Right? Especially if I'm just like, here, figure it out, dude. Right? Now, I've done that before. Right? I've done that when I've got those students that are, how should we say, overconfident. I'm still there with them, but figure it out. Sometimes you got to kind of knock them down a peg, right? But no CI should ever really do that to you unless you're, Captain Douche Nozzle. But most CIs are there to help you learn, right? But when you're scared, it shows, right? I talked about this before about faking it till you make it. Even if you are so terrified to see that patient shouldn't know it. Just pretend like it's a normal day, right? Oh, that's not working. Let's try this. Crap, I did it the wrong way, right? You can be all freaking out inside your head, but that big smile on your face and just joking around with the patient, and it'll show to your CI, because the CI will be like, you totally screwed up doing those McKinsey prone press ups. Like, yeah, I know. You're like, but good job not showing it to the patient. Right? As long as it didn't make the patient worse. I'm going to stop you if it's going to do something to make the patient worse, or you're going to do something out of my protocol. But, I loved having students that screwed up. I honestly did. Because when a student screwed up, it showed they were human. They learned something from it, right? The number one way we learn is by making mistakes. If everything in our life came easy, well, then we'd be like, Logan Paul or something. Most of us have to work for it, right? Most of us have to work to get better, and we're going to fail. We're going to get knocked down. We're going to pick ourselves back up. We're going to keep going. And that's the way you really learn in physical therapy, So what can we do to change the patient's view on pain? What about changing the cognition of the patient? Can we make them more aware of it? Changing beliefs on pain. This can be difficult. Right, how can you experience joy with it? True, right? Change the beliefs on pain. A lot of patients are, this is never going to get better. Well, maybe we can change it. What about fears? What do these patients are afraid this pain is going to go on forever, right? And you can't ever tell them they're going to get 100% better, but they're not going to ever have pain, but we can probably help them, right? But before we even get them to do therapy, we may have to change some of these beliefs in the system of the patient, right? Now, when I'm looking at this doesn't look like physical therapy to me, does it? Like changing the patient's cognition? What about their beliefs, fears? Yeah, but it doesn't, in the traditional, it's like a mental health therapist. You're exactly right, right? But that's what we're going to talk about, because we focus on the biomedical model. When do we focus on this, right? So it's now been demonstrated that cognition and pain are not just related, but they're clearly intertwined with one another. So the more patients know about their condition, the better they're educated about, the better they're possibly going to either overcome it or be crippled by it, right? Because it can go either way, right? As the patient gets more and more afraid of their condition, they're going to get more scared, right? And then they can catastrophize that situation. Oh my God, I'm never going to be it, right? What about the patient's social circle, like their family? How can the family affect therapy? Can they make it better or worse? Yeah, right? Oh my God, yeah, I know, Susan. I've had low back pain for years, and now can't even feel my big toe, and doc's talking about having to amputate 3 of my toes. Wait, what? What, Susan's friend didn't tell her is, well, they're amputating my toes because of diabetes, right? But yeah, exactly. Patients compare what they're going through, right? Oh, it's the same. It's the same. No, everyone's a little different, right? What about the interwebs? Them there interwebs. Has that made our job more easier or harder? With patients, at least. Well, obviously here teaching you guys has made my job a little easier because you don't have to see me, and you can get up and go to the bathroom whenever you want. Or Justin can fall asleep when he wants and I can't see him. But internet, oh good, see, I just test you every now and then. I already know that Plaza's already asleep, so I don't have to worry about it. He just logs in and goes and plays video games. My dog is, I put your dog to sleep, that's great. But the internet, right? It's a boon for us because we have a lot more resources at our fingertips. But for patients, man, we tell them they've got lumbalgia. What's the first thing they're doing when they go home? Right? They're like, hey, Google, tell me about this. Or hey, Siri, tell me about that. Don't you even think about it. No, stop. Right? And then, all the clinicians, depending on the clinician's attitudes, that can have an effect on them. So all this is a huge impact. And then we wonder why patients don't get better. Right? And we get so frustrated because they're not getting better. Well, all this is screwed up, right? So let's look at fear. Right? So fear is an unpleasant, often strong emotion caused by anticipation or awareness of danger. Right? I'm looking at that. And so nowhere in fear's definition does it say that that danger actually occurs, right? And if you'll ask me, what was worst about jumping out of a plane? The actual jumping out or the ride up? What do you think I'm going to say? The ride up, absolutely. That was probably the most terrifying time in my life. I literally felt like my throat was climbing out of my mouth, right? But as soon as I was out that door, I mean, guess what? There's not much I can do about it. I've got to go with the flow at that point, right? No time for fear at that point. And some of you guys have had this before. Maybe you've had something serious happen in your life, right? I've had a student before that told me that their house caught fire. Right? And initially, they got a little afraid because they're thinking, oh my God, I'm going to burn, oh my God, my children. And all of a sudden they said, oh my God, my children. And that fear shut off. And they got their kids out. Right? But some people can have that opposite effect. They get into that fear and they're stuck there. Right? Dr. Google says, fear is an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain or a threat. I think I fall in that. I look like I might be dangerous and or likely to cause pain. Or maybe a threat too, depending upon what you're looking at, right? So we go to Wikipedia. Wikipedia says, an emotion induced by perceived danger or threat which causes physiological changes and ultimately behavioral changes such as fleeing, hiding, or freezing from perceived traumatic events. Fear in human beings may occur in response to certain stimulus occurring in the present or anticipation or expectation of a future perceived event as a risk to oneself. Fear response arises from the perception of danger leading to confrontation with or escape from or avoiding the threat, known as the fight or flight response, which in extreme cases of fear, horror, and terror can freeze or response paralyze. Wikipedia also has this really interesting addition. It says, in humans and animals, fear is modulated by the process of cognition and learning. Thus, fear is judged as rational or appropriate and irrational or inappropriate, whereas irrational fear is called a phobia, right? So I'll say one word here, spiders. Right? Some of you instantly are starting to look around. Just remember, you're never more than, 12 to 18 inches away from the nearest spider. and you eat something like 500 of them over your lifetime. Right? Okay, but let's look at it. So spiders not. So I'm going to use Alex here and pick on him a little bit because he said sharks. No. Why do you have fear of sharks? Just curious. From Sharknado? Right? Jaws. Okay, good. But that shark has never done anything to you, right? Clowns, exactly, right? Open water. Yeah, that movie's not terrifying. But the shark has never really done anything to you. So technically, it's an irrational fear, right? Because you can go down to SeaWorld and swim with sharks, and they don't eat you, right? You can be in the ocean, and right? For Justin, you know, or I think it was Justin that said it, right? Yeah, Justin. Justin can go to the circus, and clowns don't turn him into their lunch, right? Unless you've ever seen Killer Clowns from Outer Space, well, then maybe I'm sorry. And if you haven't seen that movie, I would highly recommend it. It's a fantastic film, right? But the thing to me that struck me as interesting is that fear is modulated by the process of cognition and learning, right? What makes a kid afraid of heights? Because normally kids are just the most fearless, okay? The one time they fell, exactly, right? And more importantly, on top of the one time they fell, their parents' response to that fall, right? Or something happened that was terrifying at that height. Or maybe, you know, you woke up and you had a spider crawling on your face in the middle of the night. It was just coming down to look at you, see how you're doing. Maybe it was Lucas, right? Lucas was coming down to say hi. Right, well, yeah, some parents would do that, right? That's the thing, though, is a lot of our fears can, if you look back, stem from childhood trauma. And if you look in psychology, that's one of the main tenets of psychology is most of your messed up stuff in your brain comes from some form of childhood trauma. Right? Whether that's rational or irrational trauma. So a lot of it stems from me. Some of you are sitting here nodding your head. I can't see you right now. But I know that some of you are sitting here nodding your head that, you know, yeah, there's stuff in my childhood that made me the way I am a little bit, right? In a closed and small space, you say that right now, right? I know I had a best friend that his mom's way of punishing him was she had a little closet under the stairs and had one of those little plastic chairs in it, you know, the little kids' chairs that goes with those like super low tables. And even up to the point when he was like in his 12 and 13s, you know, whenever he did something wrong, she locked him in that closet and turned the lights out and literally put a lock on it. Right? No lights, no space, you know, and it was fine when he was a little kid because, oh, I'm in here, you know, I might have been mad. But then as he got bigger and bigger, that space got smaller and smaller. Yeah, parents. Oh, God, yeah, right? How many of you guys that are parents now were afraid that you were going to be like your parents? Anyone that way? Yeah, right? It's terrifying, right? And almost a paralysis. But is that a little irrational as well because you're still afraid? Good. But isn't it a little irrational because you're a different person? Right? I mean, you'll do stuff that you're like, oh, God, that's what my dad did, but you're a different person. You know, I remember all throughout my marriage, it was funny. The one thing I was terrified of, and I can openly admit this, was infidelity. I was terrified of infidelity because guess what I saw in my parents? A lot of infidelity. So it shaped my formative years, right? So it's amazing. Let's carry your grandmother's lectures, the point that I begged her just to hit me with the slipper. That's fantastic. Not fantastic, but it's kind of funny, right? So are there ways to overcome phobias, though, once it develops into that irrational fear? Yeah, but it takes work, doesn't it? Right? So what if that pain has become that irrational fear? It makes sense that at that point, the patient's going to take a while to get better, right? So how can we quantify fear? Because everything we do in physical therapy, we have to quantify somehow, right? There's a thing called the Fear Avoidance Beliefs Questionnaire, the FABIC, right? There's also the Tampa Scale of Kinesiophobia. Kinesiophobia, what would that mean? Fear of movement, yeah, right? Why do you think they're afraid of moving? Because if I move, it hurts, right? There's all kinds of standard off-the-shelf instrument, the LEFS, the LBDQ, right? The LBDQ is usually known as the Oswestry. Cognitive-based interview, right? But why do we want to quantify the patient's fear? We need to know it. We need to know for insurance, right? We need to know that we've got to quantify stuff somehow. Because sometimes the only thing we can ever, we may not be able to change everything, but maybe we can show that they're not as afraid of moving as they used to be. We're making progress, exactly, right? It's a huge thing. Progress is what we're always looking for. So this is kind of a terrifying thing here that we kind of go through, right? So let me annotate up here. I don't think I want red today. I think I want purple. So here comes the patient. They get an injury, right? So they, get in a car accident and they get whiplash. So they've had a painful experience. Some of you are going, this is way too close to home. So most patients are going to end up going along this route here, right? Oh my God, I've got whiplash. How would you know changes in fear? Well, that's the thing that's why you've got to have those questionnaires handy, Mike. Because the questionnaires are going to give them scores, just like if they were doing a Berg balance scale. And that Berg balance scale, the fear avoidance questionnaire then can show that they're actually getting better on their fear. Just like anything else. It's really hard to quantify. That's why we have some of those instruments, and some of them may not work. At that point, it's going to have to be more of our assessment than anything, right? So again, car accident, whiplash. They get this painful experience. Oh my God, my neck hurts. And then they start catastrophizing. Oh, am I ever going to get better? I don't think I'm ever going to get better. This is going to get, this is so bad, right? And then, oh God, now I start ending up in this defensive motivation and this fear of pain, right? Every time I move, it hurts, so I'm going to stop moving, right? So we go into fear avoidance. When we go into fear avoidance, we start going into disability, depression, right? Disuse. Well, because we went there and we're not doing stuff, we go back into pain. And now because we went back into pain, we go back here, things are getting worse, and we just get stuck in this nasty rotation going around this wheel. Right? How many of you guys know either a family member or a patient that's stuck in that wheel right now? I'm sure at least half of you have seen somebody, right? They get stuck in this wheel, right? They don't choose to take this exit, right? And that's kind of what we want to, when we're talking about pain neuroscience education, we kind of want to give them this new exit. So that when they have a painful experience, they look at that painful experience and go, is this something I need to deal with, or is this something that I can kind of ignore? If it's something you need to deal with, rather than catastrophizing it, let's treat it, right? We'll lower the fear, we can confront that pain, and then they can get on the slate of recovery rather than getting stuck in this wheel over here. Here are all drawings. This is a little bit of a different one here, right? There's a couple of these I have in here, right? But this depression, disuse, and disability is probably our worst area that we get stuck in, because once you get there, getting out of this loop is really hard, right? And now let's say that you've had this injury, right? This car accident. So you're in this nasty loop. Nothing's getting better. So you had the car accident. Now you're catastrophizing, right? Now you get kinesiophobia. Now you're avoiding doing stuff. Now you get disuse. And you're up here in depression, and then all of a sudden, another car accident. Now you've had another painful experience, right? Now this is doubled. And now this whole circle starts going faster. And you just exist in this really downward spiral that you don't think, nice sound effect, right? Sounds familiar, Melissa, right? I'm not using you as an example. I was not picking on you, just to let you know, right? But ideally, we want to get them off, right? We want to stop this train because we want to get off and get over here. And this no fear, I know that they say no fear in this little slide here, but I would say not necessarily no fear, but acknowledgement of fear, right? Acknowledge that the fear is okay. It's okay to be scared, right? It's okay to be scared of sharks. It's okay to be scared of spiders. It's okay, as long as you don't let that put you in this cycle where you can't do anything, right? As long as your fear of spiders doesn't give you this painful experience in your brain where you're like, oh my God, I don't want to do anything. Now I'm going to, oh God, there's spiders everywhere. Now I don't want to go anywhere because I'm never more than 18 inches away from a spider. So now I'm going to avoid doing anything. I'm going to put myself in a bubble. Now because I'm in a bubble, I'm not interacting with people. Yeah, I'll see if I can find a picture of my aunt's spider that they have in the backyard. They have a kingfisher spider in their backyard. Not my aunt's, my aunt-in-law, ex-aunt-in-laws. The spider is the size of a dog, right? So all this, here's another one, right? This is interpersonal fear model. All these kind of show the same thing. And this is looking at it from a kid's perspective, right? So a patient has a pain stimulus. The child experiences pain, right? This is where, in this part here, this is where the parent can come in, right here. When the child experiences pain, right? If we can teach them acceptance of the pain and confronting it, yeah, well, they live out in Perth, so, but if we can teach this child to confront their pain, confront their fear, it teaches them a much different way to approach pain, right? But we tend to make things worse, right? And then they develop pain fears, and then this ends up, and this stays in this childhood, which then goes into adulthood, right? We can also end up here where the child's crying so much that now the parent makes it worse, right? Because the parent makes it worse. Oh God, now the parent's making life worse for the doctors, right? All this stuff can occur, and it's just amazing how, even as a child, this looks exactly the same, right? I always like this one here, right? These are roundabouts. I had to laugh every time you go down to, when I go down to Phoenix or whatever, and I go around like those 3 roundabouts. I'm like, why are these here? Just seriously, why do you put roundabouts in? They're the dumbest things in the world. England's full of them. But this is just kind of getting in here, and the person never takes an exit. And they're just driving around in circles for the rest of their life. Right? They're stuck there. They're stuck. Right? So it takes someone else to finally come in and go, you know, that's great that you're stuck, but we want to stop you here before you lose hope. Or at least give you some of that hope back. We need to call in Dr. Phil at that point. We need to give them some of the hope back, send them to the ranch. So, catastrophize. Merriam-Webster says, to imagine the worst possible outcome of an action or event, to think about a situation or event as being a catastrophe or having potential catastrophic outcome. There's a great commercial for this, for Subaru, with teens and driving. Have any of you seen that commercial? Where the parents are like sitting at the little diner and they're looking out, and the kids out in the Subaru Outback spinning on its roof, like texting, and there's all that kind of, and so because Subaru's already thought of that, they've put in text and drive features in the car and stuff like that. Yeah, it's great as long as you don't turn them off, right? But man, I've seen this where even things of like getting healthier scare people, that they're worried that they're going to have some sort of, I'm going to have a heart attack if I exercise. Anyone ever heard somebody say that? I have heard a patient say it. Well, I know if I exercise, I'm going to have a heart attack. Right? Well, you're going to have a heart attack if you don't exercise. So, I mean, what do you got to lose? Just saying. Right? This time they really legitimately have nothing else to lose. It's not like the whole Blackwell incident at that point. Exercise equals arthritis. I've heard that one too before. Right? Just put some Vicks on it. You'll be fine. Dr. Google says, to view or talk about an event or situation as is worse than it actually is, or as if it was a catastrophe, right? In psychology, we have a better term for it. We call it cognitive distortion, right? It's an exaggerated or irrational thought pattern involved in the onset and perpetuation of psychopathological states, especially those more influenced by psychosocial factors such as depression and anxiety. So, think about it. When you're depressed, Do you tend to think things are going to get worse no matter what the problems are? Right? You're in a depressive funk and you're cooking Thanksgiving dinner and you just know Thanksgiving dinner is going to suck. Right? It's just going to be horrible. Oh God, Uncle Al's going to come over and all he's going to do is sit and talk about Trump all day. And then Dad's going to get mad about it. And they're going to end up in a fist fight. Or maybe it's just my family. Right? So we make things worse than they really are, right? Cognitive distortion, right? Or cognitive dissonance. It's where we make things worse than they really are. Some of you, I think, made that way with the interview that we gave you guys. I think some of you were thinking coming into that interview for this program that it was going to be a lot worse than it was. So I watched some of you come in that interview and man, the sweat rolling off your foreheads, it's pretty impressive, right? And then I remembered some of you that when we're done with the interview, you're like, that's it? Huh? Really? That's all, right? Little did you know that Dr. Freskin was the nice one and I'm the mean one. But it's funny how that works. Actually, you guys had Dr. Chima, I think. You didn't even have me. Especially when Ian's in your focus group, right? And Dr. Chima, man, let me tell you, with Dr. Chima, whoo-wee, she can be terrifying, right? She can be straight up cold sitting at that table. Just looking at you for that first time going, oh God, she's the one that's going to get me into this program. Okay, you know what? Working at Walmart as a greeter is really not that bad for the rest of my life, right? But you just made the situation worse. And honestly, some people that came in like that, the reason they didn't get into the program is because they did that. People that made it in were good. They're fine. A lot of the guys that made it through just talked and did things normal. That's what we're looking for. Are you a normal person? Right? Did you make it worse than it really is? So how do we look at pain as a society? Well, what happened when we made pain the fifth vital sign? Right? Did you guys ever hear this? Pain's the fifth vital sign. You gotta get pain, and we all have to get pain now, don't we? Right? We force it on you guys. You gotta get pain with every patient, even if they don't have to have pain. You gotta get that pain number, right? We've ingrained in patients that either A, they're supposed to be in pain, or B, that there's a possibility of not being in pain. So we've created a monster. Right? We also said pain is bad. We should not be in pain. If you're in pain, you're broken. Right? I mean, just watch like Dr. Phil or Dr. Oz or any of the people that have doctorates that aren't supposed to be on TV. Anytime you watch their shows about pain, man, the only thing, they're never going to talk about, okay, helping you learn to live with the pain. No, they're going to talk about, we need to get you pain-free. Really? Doesn't happen. All pain must be gone before I'm engaging in normal ADLs, IADLs, or even movement, right? Passive treatment is the way to go. Pain pills solve it all. And then no matter what you do, if you don't get rid of your pain, it will get worse, right? Work and living in a normal life will increase your pain if you don't treat it. That's some of the thoughts that a lot of society has right now. Right? And some of you guys I can feel your heads nodding even though I can't see it, right? So let's look at this Purdue Pharmaceutical conundrum. This ties into our chronic pain discussion, right? So does everyone know who Purdue Pharmaceutical is? They're obviously a pharmaceutical company, so this ties a little bit back into our pharma lecture, right? Purdue is probably the evil big baddie in the pharmaceutical world. So in the early 90s, Purdue Pharmaceuticals heavily marketed opioid-based pain relievers, which previously had only been used to treat chronic long-term cancer pain. So these are our hydrocodones, oxycodones, all those. In the 80s, that was used for patients that were dying of cancer, right? I can't think of a time that my parents coming up through when I was a little kid that they ever really got pain meds. Take 2 aspirin, call us in the morning. They really get pain meds, right? They presented research to physicians showing how opioids were no more addictive than someone taking Tylenol or aspirin. They did, literally, right? Non-cancer pain increases. In 1997, there were 670,000 prescriptions written. In 2002, 6.2 million. And then 2012, look at that jump. So in 10 years, we went up to 259 million pain prescriptions written, right? Whereas cancer pain at that time only went up by a factor of 4, right? Because it's going to go up because of population growth. Interesting number, in 2012, it equated out to be enough for every American to have a bottle of pain pills, including kids. Think about that for a second. And right now, it's actually worse, because right now, I think as of last year, it was something like 486 million prescriptions or something like that were written, some crazy number, right? So just insane. And Purdue stated that addiction rates, even with moderate and heavy use of opioids in non-cancer pain, was less than 1%. They had a study for this, showed it. What they didn't say is, yeah, that one person that got addicted, that was now 1%, the rest of the people died. So they couldn't get addicted because they've got the ultimate high, they're dead. Recent studies have indicated the risk of addiction could be as high as 50% from taking a single pill. Think about that for a second. They literally are saying you're flipping a coin the first pain pill you take if you're going to become addicted to it. You have 50-50 shot. Does that terrify anybody? Yeah, terrifies me a little bit, right? You know, so they're saying, you know, doc gives you 10 days of Vicodin for your wisdom teeth. You know, that first Vicodin you take could get you addicted to heroin for the rest of your life. That's kind of terrifying to me. 2007, they were charged in a federal court by a young district attorney at the time by the name of James Comey. I don't know where we've heard, have you heard his name before? I don't know where we've heard his name before. I swear to God, I've heard it. And Purdue, along with 3 company executives, pled guilty to the criminal charge of misbranding opioids and were ordered to pay fines of $634 million. For that whole time period, the 10 years, they had to pay $634 million. Look at how much they made in that period, though. They made over $3 billion in that period. But they lost, you know, 634 million. Drop in the bucket, right? This is how they pushed it. You know, we treated pain rather than actually treat it, we medicate it. Interesting enough, if you actually look back at some of the studies on this, yes, former director of the FBI, exactly, right? I actually met him. He's a nice guy. His book is fantastic if you ever get a chance to read it. But it's weird. We keep making these same mistakes. So after the Civil War, when we had all these troops coming back that had battle injuries, we put them on poppy seed or poppy oil, right? Milk of the poppy. And back then, we had this horrible addiction come along because of it. So then we cracked down on it, right? And then we released a new pain med that was supposed to be not as addictive. Does anyone know what the pain med that came out after Milk of the Poppy? That we, in the early 1900s up through World War I and II, that we used to treat patients with real bad pain? Heroin. We used to treat people with heroin, right? And then, you know, in the 50s and 60s, we realized after all the wars were over that, hey, this is not a good idea. Yeah, kids too, actually. Yeah, kids got cocaine too, right? But, you know, we realized, hey, you know, this is probably not the best stuff to treat patients with. I'm just saying. I'm going to look elsewhere. So along came pharmaceutical companies and said, don't worry. We've got a replacement for heroin. We got this stuff called morphine sulfate. And then morphine sulfate got bad, so then we came up with OxyContin. And now OxyContin's getting bad, and guess what? We're just around the corner from getting some new drug. We just keep repeating these habits and habits and habits. We just can't get out of it. We're in a cycle as a country as well about these pain meds, right? We need to look at pain differently. Look at it from a perspective of a traffic light or flags, right? We need to understand and watch for green lights, meaning keep going. Yellow lights to monitor. And then red lights make you stop what you're doing isn't working and change your approach. We are the quick fix country, you're exactly right. So green lights. What would be a green light that you guys would see that might indicate that your treatment's working? Well, obviously, pain gets better. Right? Pain gets better, right? Improvement in function, improvement of social cognitive function, less focus on the pain, more focus on the after pain, right? What other stuff could you see from a patient that might tell you your treatment's working? Happy patient, right? Patient's smiling. It's centralizing. Good. Right? How about all of a sudden they're actually adhering to their schedule and coming to every appointment? You'd be amazed at how much that happens. When they start getting better, they start showing up for every appointment. It's kind of weird the way that happens, because now they start believing in you. Right? And they don't want to be discharged, because then they worry that if they get discharged, it's going to get worse because they don't have you anymore. Right? All those are kind of green, like that's telling you, go, go, go. It's good, right? Now we've got yellow flags, right? Emotions, the increased fear of pain, right? Are they starting to go into a depressive funk? What are some signs your patient might be going into a depressive funk? What are some things that tell you a patient might be getting depressed? Yeah, they start looking like they're, bags under their eyes, kind of like the way I look. Lack of motivation, poor hygiene. Yeah, that's the major one, right? They come in and you're like, man, have you bathed in a week? Canceling appointments. Yep. Irritability. Yeah, you guys have all seen this with those of you that, you guys all went out a little bit of clinic, right? But you saw patients. So how are you feeling? Oh, I freaking feel great. It's just fantastic. How do you think I feel? My back's freaking hurting. Right? Yeah, I'm here, aren't I? Right. Would you think I'd be coming to PT if I felt great? Oh, okay. Anxiety or stress, right? They start coming in and now they're just totally stressed out of the world. Now other kinds of behaviors they might have. Maybe they're doing extended rest or bed rest, right? Poor compliance, or worse yet, no compliance with therapy. Extreme or exaggerated pain ratings, right? You follow up that LEFS and you give them another LEFS, and now the LFS looks worse than it did before. Excessive reliance on all forms of pain assistance. Maybe, you help them with getting a TENS unit, and all of a sudden you realize that they're literally wearing that TENS unit 24/7, 365. You told them you could wear it all the time. Yeah, well, I didn't legitimately mean like wear it until the batteries go dead and then put a new battery in it, right? Sleep changes, disturbances, lack thereof, self-medication with alcohol or other recreational drugs, especially nowadays. Because what are people self-medicating with nowadays? Especially in this state. The good old, we love you, Mary Jane, right? Yeah. Well, marijuana in general, I mean, we can look at some of the cannabis plants, the CBDs as well to go along with it. But in general, right now, I mean, everyone's touting the amazing properties of marijuana or CBD or hemp oils. And I'm not saying that they don't work. What I'm saying is we don't have the research yet on it, right? We don't know what happens if you take, maybe your CBD makes your pain better, but what's the long-term effects on your body for taking it for 10 years? We don't know that yet. Right? We're not even technically allowed to research that. We know the long-term effects of alcohol, right? Cirrhosis and everything like that. An increase in smoking, or worse yet, they start smoking, right? A lot of patients that are in pain will start smoking in order to counter the weight gain. Because it's true, when you do smoke, you tend to lose a little bit of weight, right? Or it takes the urge off your appetite. Right? That's why when you quit smoking, a lot of times, guess what? You gain weight. Family flags. They start coming to therapy, right? So grandma's coming to therapy and now granddaughter's coming with her every time. Every time that grandma comes home, her back's worse. What are you doing to her? do you know what you're doing? Right? Punitive responses. I tell you what, I'm not going to pay this copay if my grandma doesn't get better. Legal studies, exactly. right? Dissociation with the family, right? So maybe now, because the pain's getting so worse, they stop even associating with it. Maybe the granddaughter did come with her every therapy session, was there every time, and suddenly granddaughter stops coming. Right? Well, maybe it's because granddaughter has to work, but a lot of times it's because they've pushed granddaughter away. Work flags. Do they have manual work, manual labor, past work history, changes in work history? Frequent changes in work history are a sign of red flags for pain. Belief that work is actually harmful, especially if it's manual work. If I do any type of manual labor, this is going to be too hard on my body and it's going to cause me pain. In reality, if you look back in time, the more manual labor that we did, the better in overall physical health we were. Maybe not necessarily living longer, but we were actually starting to decline in physical health now in the age. So when we were more of an industrialized society, we actually were healthier physically. Unhappy at work, right? Yeah, and it just work's not cutting out for me, right? Low educational background. There's a huge, huge, huge link between low educational and low socioeconomic status and pain. And I'm just going to let it at that. Do they do shift work? Why would shift workers probably have more pain? What kind of work is shift work usually? Is it the awesomest work in the whole wide world? Yeah, it's repetitive, right? It often involves lifting of some sort, right? Or long-term sitting. It's just not fun work, right? It's not like, you're getting to play with Legos all day long. And if you did, you're sitting on the Legos the whole time. Negative work experiences with pain. Every time I go to work, my pain gets worse. Well, like, when does it get worse when you go? Well, as soon as I walk in the door. Well, did you do any activity? No, it's just literally as soon as I walk in the door, my pain gets worse. Okay. Well, that tells us that they're associating now work with their pain. Compensation flags. Lack of financial incentive to return to work, right? This is the big boogeyman that they're pushing nowadays. You'll make more money while not employed. Right now, you can. I don't think that's as big of a deal as they're making it out to be, because you still got to go through unemployment and got the pain in the butt of doing the unemployment crap and all that fun stuff. But there is this does sometimes happen, right? And you're going to get paid, paid more or enough that you don't need to necessarily work. I've seen it with disability cases where, they'll get 80% of their pay while they're on disability. And as soon as they stop having to go to work, that 80% is actually enough to cover all their bills. So they don't have an incentive to return, right? Extended time off to work because of previous lack of time off. So patients now likes this time off with this pain because now they're actually getting a day off. They're getting a week off. They haven't been able to take time off with pay before. And now because they got hurt at work, well, now they can take time off. History of repeated workers' compensation pain, the big sign, right? Previous histories of similar conditions. Talk of constant legal action. This is a big red or yellow flag here. You start seeing this, it's time to start talking to the PT. Patient's like, man, do you think I can get paid for this? What do you think? Right? Can I have paid? I know that I've lost a pinky. Do you think it's worth a couple mil? If I ask you to, would you be a witness to testify that I'm, and can you give me more time off work? I'm not quite ready to return yet. It's a yellow flag. And then talking to the clinic, this is the one I think somebody mentioned earlier. Talking in the clinic repeatedly to other patients to validate the reasons they're experiencing pain. Right? This is where Sue Ellen is talking to Mary Lou. Mary Lou's in there for a total knee replacement. Sue Ellen's in there for low back pain. And they're sharing pain stories. Right? And they're trying to one-up each other. Yeah, well, every time I get out of a chair, my pain goes all the way up to a 10. Well, I'll tell you what, every time I sit down, it goes up to a 10 out of 10. And you're just like, oh, please, just stop. Just stop. Right? All of that are yellow flags, right? Medical diagnosis flags, looking for medical sanctioning of the disability, right? I know I've got fibromyalgia. Don't you think I have fibromyalgia? Seeking multiple diagnoses and possible diagnoses that conflict with one another. My case is special. I've got low back. How many of you have heard this? I know I've got low back pain, but I've got a different type of low back pain than other people. Has anyone ever heard that? My low back pain is different. Right? This is the special patients, right? Yeah, but some of it I think stems from that everyone is different type idea, but it's kind of interesting, right? Are they looking for passive treatments? Patient comes in and what do you think? I've had this for years and I'm important as anyone here. Yep, just heard that last week, right? Or this one, the patient comes in and goes, you know, I can't do my therapy today, but you know, that hot pack, can I just get that hot pack? Anyone ever hear that? Or I just want my traction today. I don't have time to do my exercises, but I have time to do 20 minutes worth of traction. Continually seeks out providers until somebody has validated them, looks for quick fixes to the problem, right? Especially right now with CBD stuff that I was just telling you about. You know, I was looking on, you know, Mr. Bill's Pipe and Tobacco Shop's website, and it said that CBD is really good for pain, right? And he says that if I come down now, I can get 20% off my first order of CBD, these CBD gummy bears. And they said that's going to help relieve my pain. What do you think about that? Right? Repeated mention of lack of fixes from previous. You're no better than that last one that treated me. You guys just, I mean, you're all the same. You know, how many visits do you think I can get for this condition? I had that one back when I was at the clinic. So do you think this is going to be an 8-weeker, or do you think maybe 12 weeks you can get for me? You know, if it hurts, should I avoid it? Every time I bend over and do this, it hurts. So that means I shouldn't do it. Well, maybe not, right? And then red lights. So before we get down through the list, what would you guys see? You're treating a patient, what would be a red light telling you, I need to stop treatment, I need to go talk to your PT as a PTA? You're treating a low back patient maybe. What would be some red lights? Like flashing a red light, stop this treatment now, I need to get off. Pain screaming, yeah, there we go. Thoughts of suicide, excellent. That's one of those where you may want to have a different form of communication with your PT. I know a lot of times if you're working in a chronic pain clinic, you're going to have your phone on you at all times, because you don't necessarily, if patients starting to talk about suicide, the last thing you want to do is leave them alone. Right? So maybe, you know, send a text out to PT going, help 911 now in the room. Right? Send an email. Yeah, hold on, you know what? I've got to send your doc a quick email about this. Right? I forgot to send them your study last time. Right? Pain, the pain that just explodes. Right? Patients screaming in pain. Oh my God, what are you doing to me? Probably time to stop. Right? Pain migrates to different predictable pain pattern, dermatomyotome, where it's a different pattern, right? Continually getting worse from the societal world, right? The patient begins discussing what would happen if you got litigation against you. That's a red flag. So just curious, does your clinic have malpractice insurance? How about you? Do they make you carry malpractice insurance? It should, right? You all should. But when you start hearing that from the patient, you really should be thinking, I am 5 seconds away from a subpoena here. Right? I've had clients will do that for me. They're like, so how much do you have in malpractice insurance? My normal answer is to that, not enough. Or the clinic takes care of me. Right? I carry my own malpractice insurance just because of this. And how does one, I've had this before, how does one go about filing a complaint about, you know, a PT? That's when you're going, wait, is this complaint about me? Is it about PT? Is this a complaint about? I'm getting paranoid now. Or even a compliment. How do I file a compliment? I want to let the state board know how awesome you are. That should be a red flag, folks. No one wants to send an email to the state board about how awesome you are. No one. No one wants to tell your boss how awesome you are. What do they think they're going to email the state board and tell them you're an awesome clinician? Right? just that malinger a person are red flags, right? So pain is malfunction in the cognitive process. Patient suffers painful experience, becomes afraid of the painful experience, poorly understands how to resolve it, worries about further damage, suffers another painful experience, and they get stuck in that cycle we already kind of talked about. So modern thought of pain is that pain is a multiple system output activated by the brain upon a perceived threat. And that's whether that threat is real or not. So this is interesting, is that epidemiological studies show that chronic, widespread, non-specific musculoskeletal pain is on the rise, especially in chronic low back pain. And some studies have indicated that chronic pain may be as high as 35% of all patients visiting the healthcare provider about pain. So about a third of all patients that come in for some sort of a painful complaint are actually chronic pain patients. Americans account for only 5% of the world's population, but consume 80% of the global opioid supply. And this is terrifying. We consume 99% of the hydrocodone supply of the world. 99%. The rest of the world gets 1%. Right? So that means we have to treat the brain as well as the body. And this is the big thing that we need to get at. This is hard for us. We didn't used to be this way, right? Because you usually think, I'm a therapist, I'm not a psychologist. Well, your hat's changing now. You got to put a little bit of that psych hat on and start talking to your patients, right? So how we've thought about it in PT before. The main reason of pain is a stiff joint. The main reason of pain is a tight muscle. The main reason of pain is an altered, incorrect muscle recruitment. The main reason of pain is trauma, wounds, etc. Could those views be flawed? Yeah, absolutely. Because you can have pain without any of that. Right? You're going to tell me that mental pain is not pain? No, it is. So let's look at this patient here and see if this sounds like any patient you've had. Hi, my name's Edith. My pain is due to chronic bulging disc L3, L4, L5, L6, and L7. I have bulging disc because I have arthritis and degenerative joint disease, which has caused me to get degenerative disc disease. Now that I think I might have that fibromyalgia stuff, or maybe lupus. I mean, I've had a weird rash on my face for a couple of weeks when I wake up. My pain meds aren't working any longer. I only take them when I need them. But are there stronger ones I could get for me? I really shouldn't exercise. I read I shouldn't exercise until all my pain is gone, because the pain is the body's way of telling you to stop until you don't have it anymore. Well, maybe I have this rare blood disorder I read about. Have any of you ever seen a patient like this? Or a family member like this? Because I guarantee as you guys get further and further in your career in PT, right? This is like, I churned this out in a few seconds, but this is legitimately like, and as you guys get further and further in your PT career, more and more of your family members are going to start coming to you for advice. They may even come to you now as a student, right? Oh yeah, that's right, you're in physical therapy. Yeah, so I've had this back pain. And when I get people like that, I'm like, I don't treat back pain. I work with kids. But yeah, it's amazing how this happens, right? It's just this terrible, that patient right there is your average chronic pain patient, right? So there's a slight flaw in our education. In physical therapy, we approach all diagnosis on a prevailing biomedical model that focuses on tissue and tissue injury, right? Orthopedic-based professions like ours and chiropractic commonly use anatomy, physiology, and pathophysiology to explain to the patient what's going on, right? And I forget who said about breaking out the spine model, but this is exactly what happens here, right? So if you look at this little model of the knee I have here, these brown structures are your ligaments, this white material is your meniscus. The red beefy looking stuff, well, that's your muscle. You have a microscopic tear, we think, of your medial meniscus, which is impinging, not allowing the knee to move freely through its range of motion, bending the knee around. This piece is catching, which is where you experience pain. Anyone ever see like a PT or somebody explain it that way? Or something similar to that? You know, maybe with the bulging disc? You know? Nope, never? Oh, that's the typical way we do it. We're going to show them these models, right? And try to explain to them, but the patient's looking at the model and going, wait, that's what my knee looks like? Where's my skin? Or stickers, well, that's one of the things I was going to say, right? Next one's, you know, well, if you look around, so it's one of the questions there, what kind of science literature do we keep around our clinics? Well, there's big pictures of people in pain, right? Studies have shown there's a limited efficacy in decreasing pain or disability by looking at purely the biomechanical model. And actually, studies have indicated that purely biomechanical approaches may increase the fear in patients, which may increase pain and further fear avoidance. One study indicated that almost half the people with a bulging shifted disc displayed no signs of low back pain. Think about that. They looked at a bunch of people. I want to say it was 400 people they did in the study. They did MRIs on the people. And of the people that had bulging or herniated discs, 50% of them had no signs or symptoms whatsoever. Disc may actually be absorbing some of that shifted weight, right? Now, what happens if they tell that patient, oh my God, you've got a bulging disc? What's now going to happen? Right? Patient's in no pain, but now they're told they've got a bulging disc at L4, right? Like that old lady's L7. Yeah, they start having pain, right? Psychological pain starts kicking in, right? And this usually happens when something silly happens, like maybe they've got really bad constipation and they're sent in for a x-ray or something of their bowels to make sure they don't have a bowel blockage. And then it'll say somewhere along there, it'll say something about incidental or anomalous bulge at L3, L4. And the patient looks at that and goes, oh my God, my back's broken. Oh, yeah, now that you mention it, oh my God, yeah, I can think about it now. I've had back pain for a while now. No, they haven't. Study done by Tate, Levy, Noel, and all, right? Patients who underwent a this is interesting. This study was fantastic. Patients who underwent a microdiscectomy. What's a microdiscectomy? For those of you that have seen it, what's a microdiscectomy? What are they going to do? Yeah, they go in and take out a chunk of the disc, right? Usually they cut and shave off the part that's bulging, right? The patients were shown the bad material in a little jar, and they were given the bad material. The patients that were given and shown that material did significantly better than those who weren't shown it. If you look at this, leg pain, 91% got better versus 80% that weren't shown it. Back pain, 86% versus 75%. This was the one that blew my mind here. Look at this. Limb weakness, 90% got better versus 56% that didn't. And even paresthesia, look at that, 88 to 62 basically. And then reduced pain medication use, 92 versus 69. Just by giving them a little jar. It almost makes you wonder if you just gave them a jar of stuff and told them this was the stuff. Right. But what happens if you, instead of you just put a little incision on their back, you stitch the incision up and you hand them a jar with junk in it and say, all right, your back's fixed. Do you think that might fix some patients? Probably would. I mean, it's really working on the placebo effect there, isn't it? You could also really mess them up. You could change it up and you're like, hand them this jar, right? And go, oh my God, look at how much of this material I took out of your back. Oh, do you see how black it is? It's so necrotic. And all of a sudden, what's probably going to happen to their pain? Now they're going to get the nocebo effect. They're going to get worse. Because you just told them, oh my God, my back's necrotic. What the heck? So this is interesting here. This is low back pain versus arthritis over time, right? So development of arthritis increases as we get older. But look at low back pain. Look where low back pain peaks. Through the late 30s, early 40s, into the 50s, we have low back pain. But as they get older, they stop complaining about low back pain. Now, some might say that they stopped complaining about it because either they're dead or they forgot about it because they've got Alzheimer's, right? But even with arthritis going up, low back pain goes down. That blows my mind. Spielman looked at this and looked at rotator cuff injuries. Here's another great one. 1/3 of people over the age of 30 that they actually scanned have abnormal findings on their MRI in the rotator cuff. So that means if we went around the classroom right now with 26 of you guys, about, what would that be, about 7 or 8 of you guys would have abnormal findings in your MRI. I mean, we already know 1, right? 2, we've got 2, 3. Where's Russell at? He's got an abnormal finding, right? And then, yeah, he's got a lot, right? 2/3 of the people over 70 have abnormal findings on their MRI. That makes sense, right? Once you get over 70, everything's starting to break down. But 60% of the people reporting rotator cuff pain are under 45. Think about that for a second. Only 1/3 of those people have pain, but they represent 60% of the people reporting it. And this is interesting. After a successful rotator cuff repair, 90% of the people have further abnormal findings on an MRI. So they get their problem fixed. Yeah, it's going to be sore. Actually, you may honestly not even notice it when you get older, Russell. It may just get to the point where, yeah, it does make you tough, right? You just kind of start ignoring it and realizing it. I've got my aches and pains and I got to deal with it. But this is funny. 90% of the people that have surgery to repair an MRI end up with further abnormalities on their MRI, because that means they didn't fix the problem that caused it in the first place, right? Studies have shown that outpatient physical therapy may be far more beneficial than rotator cuff surgery, right? It's true. Studies have shown that. Does that benefit our field? What do you think? Absolutely, right? Yes, right? But does it benefit the patients necessarily? Maybe not. Because to them, they hear terror and they've been trained to think surgery. So as soon as they come into you, they're already assuming that you're not going to do any good, right? You've got to learn to talk to them a little different. All right, so let's look at a situation here. You're in Vegas, so walking down the street singing do-wah-diddy-diddy-dum diddy-do, right? You misjudge the next edge of the curb and your right foot slips off the curb. You completely invert your foot to the point of a complete stretch of the lateral compartment. Ouchie, sprain. Initially, you get a shock of pain, mainly by looking and seeing it happen. All right, Justin. As you do this, you notice a guy coming careening at you in his Mustang, not paying attention at like 50 miles an hour. What's going to happen? So you're kind of hanging off the curb, your ankle's bent all up and twisted. You're going to get out of the way. Most of the time, right? What happened to the pain in the ankle? Because literally you can probably run out of the way. What happened to your pain in your ankle? It's gone, right? Your survival instinct is going to override it, right? Your brain says at this point, that threat is greater than the threat of my ankle. I need to overcome that threat and I'll worry about this threat later, right? So that means pain is a decision of the brain based on the perception of a threat. You can talk to patients about this. It blows their mind when we talk about it, right? And pain's just that multiple system output, right? Literally means pain is a learned experience. It's a neural signal activated when the brain perceives a threat. Even if that pain doesn't really exist, they can have pain. I'm thinking of patients that don't have a leg and they've got pain, right? There is no threat there. They've still got it, right? So if the brain perceives a threat, they've got to determine how dangerous that threat is. If the threat is dangerous, they're going to be looking for more information. If they get that more information and it shows that that is really a dangerous threat, you get an initiation of the pain response. But if the threat's not dangerous, and maybe something else is more dangerous at that point, you get an inhibition of the pain response. So we're looking at this, we can go, oh, hey, we can actually inhibit our pain responses, right? What we realize is pain is a lot more complex than we used to thought to believe. We used to think pain equals injury, injury equals pain, right? But then we have pain without injuries. How does that happen, right? And right now you guys are thinking my brain is in pain, right? I'm pretty confident this lecture is a perceived threat and my brain is in pain right now, but that's okay. We're going to talk about how you can overcome that in a few seconds here, right? So pain neuroscience is an emerging field that shows explaining to patients their pain perception experience from a biological, physiological, and psychological perspective of how their nervous system, brain processes everything, allows patients to get better, exercise better, think differently about pain, and push through pain harder. This does involve spending one-on-one time with your patient on something other than pure physical therapy and more on education, right? This is where it gets a little hinky because we don't necessarily have reimbursement for this. That's why a lot of people don't do it, right? So PNE, which is pain neuroscience education, looks at adjunctive therapy, meaning manual therapy, soft tissue development or mobilization, right? Neurotissue mobilization, spinal stabilization, home exercise program, circuit training, aerobic training. And then also looks at, well, what happens if we don't have any adjunctive training? And it's interesting, the studies that just looked at pain neuroscience education, they didn't even do adjunctive therapy with it. The patients showed a better improvement in pain than people that got therapy. Because the clinician said, yes, you're in pain. I understand that, I acknowledge that, now let's work through it. It's just interesting the way the brain can work that way, right? So PNE, we're going to talk about the neurophysiology of pain. Now, here's the thing. If you want to follow this PNE pattern, right, pain neuroscience education, you have to understand pain, which means you're going to have to read a little bit, right? You have to stop referencing purely anatomical biomechanical models. It's okay to reference those every now and then, but the pain isn't coming from that model. The pain's coming from the brain. So we need to teach them about the brain, right? We got to talk about those nociceptive pathways, right? What's causing pain? Talk about the basics of a neuron and neuronal pathways, right? Including fiber types, the type 2 fibers, type 2Bs, type 2Cs. How the neural body looks, what are the dendrites, what are the axons, how the synapses work, what is an action potential, what is depolarization, what is hyperpolarization. You're providing them with more info to make a more informed decision about their pain. How can we inhibit that pain? And then also teach them that their nervous system is plastic, meaning that we can actually override some of that pain. How many of you guys have heard these two terms so far? Peripheral sensitization and central sensitization. Have any of you heard that? Somewhat. I guarantee you're going to have a few questions on your boards about these, right? And that's why I kind of put these as one slide. Peripheral sensitization, according to all your textbooks, is an increased sensitivity to afferent nerve stimuli. This occurs after there has been an injury or cell damage to the area. It produces a flare response due to nociceptor producing a lot of neuropeptides, primarily substance P, which results in an increased sensitivity to heat and touch stimuli, which is referred as primary hyperalgesia or primary allodynia. If the stimulus was not painful one prior to the injury, now they will get a painful response, right? So now a gentle stroke, which before the injury was not painful, is now interpreted as pain, right? So peripheral sensitization is a lot of time where you have an injury and now you have pain in that area that's abnormal. You shouldn't have pain there. If you touch them, they get freaked out and it hurts, right? Versus central sensitization, which is a neural process of encoding noxious stimuli in the central nervous system, right? Central sensitization is described as an increased responsiveness of nociceptors in the CNS. So your body with central sensitization, whereas peripheral is looking out at those peripheral nerves now responding errantly. You know, you get touched and now that touch is actually causing pain, or the temperature goes up and that causes you pain, right? You get thermalgesia. Central sensitization, you're adjusting those thresholds to stimuli, right? And you end up with a subthreshold afferent response, meaning that maybe it takes a little bit less to throw you into that pain response. You get a hypersensitivity to stimuli. Maybe your reflexes are overreactive. Maybe that pain response is overactive. So if I do poke you with a pin, rather than it just feeling like a poke of the pin, it now feels like I'm stabbing you through the arm, right? They usually have a responsiveness to non-noxious stimuli, and they have an increased pain response evoked by stimuli outside the area of injury, meaning that they have a pain response that's going to show pretty much all over their body because the problem is not peripheral at that point, it's central. So the main difference is just where that processing problem occurs. And the real problem becomes when you have a patient that has both peripheral sensitization and central sensitization. Because at that point, their whole pain system is jacked. And you've got to figure out which one you're going to treat first because you can't treat them both. So looking at what we discussed, altering a patient's way they perceive and receive pain can potentially alter their pain experience. Patient experiences an event, they go to a medical professional. They go to a doctor, they get prescribed meds. They go to a surgeon, they'll get prescribed surgery. They go to a chiropractor, they get prescribed bone cracking, and then maybe some other stuff depending upon where the chiropractor went to school. They go to a traditional physical therapist, they get prescribed physical therapy. They go to a naturopathic practitioner, I have no idea what they're going to do, but I have a great imagination about what they'll give them. You know, they go to a psychologist or psychiatrist, they get told it's all in their head. And in reality, all in their head is the most correct answer because pain is there, right? So we've got to adopt some of that. We also have to be kind to our patients and know that if our treatment's not the best treatment, we got to refer them to the proper place, right? What if instead of looking at the biomechanical reasons, we continue to treat them in conjunction with the brain down to the body? Can we break that pain cycle, right? Can we alter their perception of pain? Can we alter their life entirely, right? If they've lived in pain for so much of their life, and I've seen this before with people that are really gifted in pain neuroscience, patient has been in immense pain for so long, for years, and they've seen a pain neuroscience specialist for 6 weeks, and all of a sudden, like, they have this breakthrough moment, and all of a sudden they may not be pain-free, but that pain's no longer crippling them. Right? It's just amazing to watch their faces when that happens. And can we alter our ways of practice, right? So how should we use PNE in the clinic? Well, it's a clinical step-by-step how to do this is in numerous books. Here's the deal. I'm not going to teach you all about PNE today because there are like 30 books on this, right? But the application in the clinic is directly proportional to the education you receive, right? When we talk about PNE here, you're going to go out in the clinic and you might mention PNE to one of your clinicians, and they have no idea what it is because they've never encountered it. They haven't encountered the research on it. They haven't looked at, somebody's never talked to them about it, right? But this really happens out in the real world, right? Somebody goes away for a course, for a weekend course on dry needling, and they come back from that dry needling course, and all of a sudden, everyone under the sun is getting dry needled, whether they need it or not. Because they've got to justify the spending on that course, right? The same thing goes here. The more courses you kind of look at, the more you'll start seeing how this is kind of realistic. But it's only one phase. It's just like everything else we've talked about in physical therapy. Modalities won't fix a patient. Exercise alone may not fix a patient, right? If they don't change their behavior and be open to that change, we won't fix them. We also, as a clinic, have to be more open to making changes, right? We have to be accepting that we may not get reimbursed on every single minute we spend with the patient. There may be some minutes we're eating. And I know clinics don't like to do that, but we may have to eat them for the greater good of the patient. And looking at other clinical application pearls, just starting down this path is only the beginning. It's going to take education, education, education. And really, we're going down this route. Eventually, we're going to be moving down this pain neuroscience education. We're going down it as a practice. It's either people get on board with it or they get run over by it, right? So here's typical questions that we talked about at the beginning, right? This is kind of stuff that you're going to ask your patient. All these questions look kind of familiar when you see a patient. Right? They look kind of just, they're our average question. So are these kind of short, quick answer questions for the patient? They are, aren't they? This is going to provide us a ton of detail. I mean, not particularly. I mean, except for maybe what makes it worse or what makes it better. Or what do you want out of your therapy? I want pain to stop. But what if we change the game up a little bit? And we ask them, what do you think's going on with your condition? What do you think should be done for your condition? Describe exactly. So this is a look at. These questions are similar questions, worded a little differently that'll get you more information. Why do you think you still hurt? What would it do to take for you to get better? Where do you see yourself in 3 years with regards to this condition? And I always ask them, where do you see yourself in 3 years if this pain doesn't get better or if it does get better? What gives you hope? We can use that. What is your expectation as me as a clinician? What are you looking for from me? Right? I love this one here. This is a great question as a patient. If I could wave a magic wand over you and take your pain right away, right now, what things that you've stopped would you start up again? That tells me their motivation. Right? Are you angry at anyone or anything about your condition? So let's explore that a bit. Tell me about it. Has anyone made you feel like you're just faking it or telling you it's all in your head? Even though reality, we're eventually going to tell them it's all in their head. Right? Does your work lay guilt trips on you for your condition? How does that make you feel? If you could do anything tomorrow without pain, what would it be? right? This approach is a little bit more low tech and is a lot more cognitive behavioral therapy like psychology, right? It's more listening than it is therapy. And you may be the first person to actually listen to the patient, and you may get the patient that absolutely breaks down on you for asking these questions, right? But nothing in any of those previous questions is a physical therapist only question. You're making no assessments there. There's nothing in any of those questions that says that's a physical therapist only realm. All those questions are is just making you a detective. You're looking for the breadcrumbs, right? And then starting the pain talk. Has anyone ever talked to you about why you're hurting? Would you like to know how pain is, or know why your pain's not getting better? And before we start physical treatment, can we discuss more about how your pain works and your knowledge of pain? Talk to them about those neurons. And can we possibly explain why it's so easy for you to suffer in pain, right? What's causing them to get stuck in that little rut? And then you may have to explain action potentials, right? So what's the body's normal resting membrane potential? Do you remember this? What's the normal? Minus 70 millivolts. Good, right? So what's the normal firing potential then? Minus 50, 55, somewhere in that range. Good, right? So we still got some people awake. What happens if you get graded potentials? Remember those little repetitive time and time again that don't quite reach that negative 55. What's going to happen? Does anyone remember that from anatomy? Let's go with blue. Blue sounds good, right? So remember, here we have our action potential grid. Let's get another color here. So yellow's our baseline, right? That's our minus 70. And then go over here. Purple's our firing line. We're going to say minus 50 just to make it nice and even. Yes, it pushes that. It can either push the threshold up or it keeps you locked up there, right? So where's my little mouse? Oh, there it is. That was not supposed to be there, but just ignore that. Clear that one. Undo that one. There we go. Right? So remember, the graded potentials are the ones that go up close to that, but don't quite hit it, right? And you're back down here. And you start getting these. And what happens is this minus 70 now goes up here. So now your resting potential might be minus 60. Right? That makes your overall nerve function hypersensitive, right? Because in order to fire off when you're at normal potential, right, you have to have a change of 20 points to get that action potential fired off. But you get all these graded potentials, and then you get stuck up here in this minus 60 where your resting is. Now it only takes 10 to fire off. So now you're hypersensitive to all your activities, right? That's going to cause that resting membrane potential to change, right? And then just as quick as it changes, it takes a lot longer to return to normal. It's just like anything else. To get back to a normal functioning state, it usually takes 2 to 3 times as long as it takes to get to an altered state, right? And a lot of times we don't even know this is happening to us. But I know some of you parents can relate to this, because sometimes your kid's sitting there and they're just doing something that's just enough to annoy you, but not enough to make you do something about it. Maybe they're sitting there with their pencil and they're clicking it. Click, 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 click. And you're sitting there going, okay, that's really annoying me, but you know what? It's not that bad. I can focus on something else. Right? Click, 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 click. Yeah, I'm fine. And then the kid knocks over the cup of water. And that cup of water goes right under your laptop and fries your laptop. What happens to your response to that? A normal person. I know you guys are all going to be perfect. Well, what's going to be your response to that? Is it going to be a heightened response? Being honest, it's going to be. Yeah, right? It's just going to be. Because you're already at that agitated point And now that agitation is just totally depolarized. And now you're off the wall, right? Same idea with the resting potentials of the nerves. Same idea there, right? At the clinic, after starting PNE, we got to do something physical with them as well. They've got to do some exercise. They've got to do some movement. They've got to do some breathing and relaxation. A lot of pain relief is going to start with teaching them how to breathe right and how to relax right. And sometimes teaching them to relax is just nothing more than teaching them to breathe, right? Getting what kind of good breathing going on that you all got trained in and had a comp on it. Diaphragmatic, right? Maybe even some pursed lip breathing to try to kind of change things up a bit, right? The patient needs to be given some homework. They need to be given something to think, read, and do some questions on. You gotta tell them you're going back to school. This pain, treating your pain is gonna be like going to school for a little bit. I'm gonna do some homework for you, but I need you to do some homework for me too. They need to get a walking program in. What if your patient only says, I've only got 5 minutes a day that I can walk? What do you say? I only have 5 minutes out of my day. That's all the time I can devote to walking. Congratulations. Let's do that 5 minutes a day. All right. They should only be given 2 to 3 basic exercises, no more. Right, I'll take it. Don't give them more than 3 exercises. Studies have shown if you give them more than 3 exercises, they'll do none of them. If you give them 2 to 3, they might do 1 of them, right? But they need to understand that if they want to get better, they have to work at it. And then goals have to be set every week, right? All right, so this week, I want you to do 5 minutes of walking, and I want you to do 10 reps of each of these exercises. Next week, we're gonna reevaluate. Next week, I'd like you to try to do 6 minutes of walking. We're gonna do 15 of extra exercises. It helps them understand that we're gonna progress, right? Looking at pain, explain to them, pain is normal, right? Pain is there to protect us, but it can also hurt us. If we can change the way a patient sees pain, it will help, right? Patients are truly interested in their pain. They wanna know why they're hurting. They wanna know how to get better, right? And they can take on this modern science, right? If we can turn down the body's alarm system therapeutically by doing PNE, by doing aerobic exercise, by doing manual therapy, pace them, graded exposure to more and more activities, and then breathing relaxation, it's amazing what we can do with pain, right? A lot of the clinicians that are out there, when you hear about PNE, talk about, well, this is hands off. This is just talk therapy, right? This is what you do if you're a psychologist. Not really. This is why this stuff really interests me, because it's a combination of both physical and psychological therapy. And I see the real links between them, right? We're a little bit of a detective. It's got to be used in conjunction with traditional therapy, right? The more we listen to the patient, the more the patient will provide us with the breadcrumbs we need to help them. Education by itself is limited unless there's follow through. And the patient has to want to follow through. We can't lead, the good old theory, we can lead a horse to water, but we can't make them drink, right? Education on diet is just as important as the rest of therapy. And a lot of these patients are gonna need to keep a weekly food diary, right? Looking at what they're eating. What are we looking for in their diary, their food diary? What kind of stuff are we looking for? Some of you health nuts out there in your diets and your food, right? Consistency. Are they eating a consistent meal every day? Right? What else could we be looking for? Proteins. Yep. Are we getting proteins in? That's a big one. And to go along with proteins, we got to have the other side too. Yeah, the veggies. You got to have some veggies to give the vitamins and nutrients, right? And we also look into those empty calories, right? When I say empty calories, what am I talking about? Yeah, anything with excess sugar, right? Now, does that mean they can't have a Twinkie? Yeah, alcohol's another one, exactly, right? Does that mean they can't have a Twinkie or they can't have a glass of wine? Absolutely not. They can have it, but they can't eat a whole box of Twinkies. I don't know who could live through a whole box of Twinkies, but I mean, right? There's got to be a balance there. And maybe that's where the first week they come back, you're like, man, look at all this junk food that you're kind of eating here, right? Let's look at how we can change some of that. Right? And then we need to reintegrate them in normal social function is just as important. We need to tell them how they're going to get back to their normal life. So we're going to hold their hand and we're going to provide them with the STDs again, right? We're going to show them what we're going to do for them. We're going to tell them how they're going to do it, and we're going to have them do it. Do seems really important or really inappropriate here, right? We're not going to do them. Have them do it. No laughs. Let's hope for at least one. Amen. We're going to provide regular and consistent feedback, but change your feedback techniques. Use some of those different techniques that you should have learned in TheraX 1, like bandwidth feedback, where you're providing it over the whole time. Faded feedback, where you provide the feedback at the end of the session, right? Upfront feedback, where you talk about the previous session and how you're going to change this session. Changing that feedback is really important to break that cycle, right? Discuss new sensations, right? So patients working with you and all of a sudden they're now saying, oh my God, you know what? Man, my butt doesn't hurt as much, but my back's killing me now. And again, we've talked about that before, that centralization. Great, that's what we want, right? Explain to them what's happening. Relate it back to pain neuroscience. Let them understand how that's where we're going. Every session, ask them about their HEP, not just exercise, but also any journaling you ask them to do. They should be bringing their HEP into you. They should be talking to you about them doing it. Then this is where you get advanced. Now start integrating the HEP into their ADLs and IADLs and make them appropriate to what they do, right? So if you're having them do pelvic tilts, have them do pelvic tilts while they're typing up their spreadsheet for work or while they're taking a conference call, right? Make it functional, exactly. They are more likely to do HEP if it's revolving around their job, right? Have them integrate their own little low back program into their work. So they have everyone standing around in their job doing a bunch of pelvic tilts and standing and some extension and standing and stuff like that. Make it fun for them. Because I guarantee if Sue needs it, John, Sammy, and Charles need it too. They're just not coming into you, right? The 10 pearls here with PNE that I've kind of covered from the whole time. You have to be smarter than your patient. And by that, I don't mean you have to be a whiz kid. What I'm meaning is you have to be able to predict everything your patient's going to say to you. And if you can't predict it, you have to be able to redirect until you can handle that objection, right? Education should be paced. Don't dump the entire catalog of PNE on a patient the first visit, right? This lecture was, I think, 56 slides. I dumped it on you in one lecture. How many of you guys right now feel like your brain is on overload? Yeah, right, a couple of you. Just imagine just doing this whole thing on your patient. They're never going to come back to you, right? So you got to do a little bit at a time. This is why some of the way education is done isn't the best idea, right? If we could, education would be small bits of education over a long period of time, but we just can't work that way to get you guys degrees. It's not the way it works. Remember that all you can do is plant the seed in the patient, right? You plant the seed, you water the seed, and you watch for it to grow. Don't force it, but look for back doors as well. So as you're trying to get them to go along this pathway with you, and maybe they're not going the best way, look at other ways you can influence them. Kids, spouses, children, anything to that along the way, right? And tether your treatments. Make sure if you're talking to them about talk therapy with PNE, it's tied together with their physical treatment, which is tied together with their diet, which is tied together with their sleep journal, everything like that. Nowadays, we have some great things for tracking what the patient's doing in a day, right? I know half of you guys have an Apple Watch or Samsung Gear or something to that effect. That thing is like the best tracking of what the patient's doing in the world. I think the new one is actually going to, I don't know if the new one, I think the 5th edition has sleep tracking in it too. So, I mean, it's gotten to the point where they only have to track that. It will give us a heart rate over the whole time they've had that watch on, right? So it'll also tell you where they've been, which can be bad if you're sneaking around with your spouse. But hey, I mean, what do you want? And set boundaries for your patient and for you, right? Make sure they understand what you're willing to do for them, but also make sure that this is what if you want me to, if I want to treat you, you've got to set and this is not only for PNE. I really think you should do this for all patients. Set their boundaries of what they're expected. You are to be here on time, and by on time, I always tell my patients, by on time, I'm not meaning if your appointment's at 4 o'clock, you need to be here at 4 o'clock. If your appointment's at 4 o'clock, I expect you here at 3:45. If it's a re-eval day, I expect you here at 3:30. I make my expectations very clear to my patient. I was talking to a PT down in Tucson about this because my patients are always late. I don't understand why my patients are always late and blah, 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 blah. And then I started talking to them and I find out, well, guess what? They're always running late themselves. So they're always getting caught up in the previous patient and getting stuck, and then they're late to go see the patient. So then the patient thinks, well, if you're not going to respect my time, why should I respect your time? Right? Don't miss appointments, both you and them. If you say you're going to be there for them, be there. They need to not miss appointments. If they're going to miss an appointment, they can't talk to the front desk. They have to talk to you. And then both of you have to do your homework. If you tell the patient you're going to go home and look up something for them or come up with a better exercise for them, do it. If you give them homework, they have to do their homework too. These are kind of expectations you set. Just remember though, your patients are smarter than you think they are. And this is to a point. Sometimes they're a little too smart for their own good, right? So they're going to be able to do most of the stuff, but don't dump everything on them. And remember that all pain is real, even if it's in their head. And remember that pain is subjective. If your pain level right now from this lesson is a 10 out of 10, I can't tell you that your pain level is not a 10 out of 10. To you, it's a 10 out of 10. I have to acknowledge that and then remind you that this lesson's almost over. The more detailed they do their homework, the more breadcrumbs you have. And I talked about vestibular with breadcrumbs. I'm talking about this with breadcrumbs. The more breadcrumbs you have to follow that trail, the more you can lead Shaggy and Scooby to whoever the guy is under the mask of the ghost, right? It helps you unmask that bad person. And movement is still the best and biggest painkiller on the planet. The more you move, the better you feel. So eat your moves with every meal, right? Get those patients moving. Motion is lotion. So I could put a couple different books up here. I would recommend all of these books to read. The two books over there by Adrian Lowe are really quick books. The Why Do I Hurt and Everyone Has Back Pain. I think they're maybe 100 pages. They're really thin, small, spiral bound. Have any of you seen those two books? No? You guys are all asleep? I love those two books. Those are my favorite. And I actually, for my patients, when I was working an outpatient, I kept about 5 copies of Why Do I Hurt? And I would give them a copy. Sometimes some of the patients I'd loan one out to so they could go read it, but others I'd give a copy of it. It's, I think it's like $10. But it's amazing when you give them one of those books to read, they come back and like, oh my God, now I understand why you're doing X, Y, and Z, right? World of Hurt, Guide to Classifying Pains, another great book. Both the Dewage books, The Brain That Changes Itself and The Brain's Way of Healing, really are, it's not always dealing about pain, but it just shows you how magical the brain is. It just amazes me when you're looking at it. That the brain can change itself just by simple, little simple changes you make every day, right? I mean, you can change how functional you are just by taking 10 more steps every day. It's little changes that will lead to big changes. And same thing with pain. A little change in pain can lead to a large change in pain. The main idea is getting that lion under control. All right, any questions? Other than, can we please stop? My head hurts. And I would tell you that that pain is actually in your head. And let's explore it a little bit. What's caused that pain to increase? What makes it better? Is there anything do you have somebody in your family that doesn't acknowledge your pain? Stop share. So overall, what do you guys think? It was painful? Okay, good. Is it different than the way we think? So it depends. So Alex, some insurances will allow you to bill for it's called patient education. You don't get reimbursed a lot. I think it's like $3 or $4. It's not the major. But if you're going to start, if your clinic's going to work towards this pain neuroscience education kind of method, your clinic has to understand they're going to lose a 15-minute block, about every other visit with the patient, because that's going to be used to kind of go through these processes with them. Does that make sense? And I always look at it because when we started implementing this, we had one clinic back in Pennsylvania that was all they did was pain neuroscience. They saw all the chronic pain patients. And let me tell you, that clinic could suck your soul, seeing nothing but chronic pain patients every day, all day, 20 of them in a day, right? Because you just realize how bad some people have it. But what we realized is that if we did spend that extra 15 minutes maybe where we didn't bill them and just sat and listened to them for a little bit, they were likely to refer somebody else to us. And yeah, we lost that 15 minutes, but we made it up in 50 visits with the next person. Not 50, but 10 visits with the next person. Referrals are a source we miss out on a lot. But it's just really interesting. There is a patient education CPT code. I can't remember what it is off the top of my head. I know it's 9701. 001 is eval. 02 is re-eval. I think it's 05. It's been a while since I used that one. But it does exist. So why do you think we don't do more of this in the clinic then? Why do you think we don't focus so much on the pain neuroscience side of it? Time. Yeah, the big one is going to be time, right? Money too. And the numbers in outpatient, right? Yeah, exactly. I mean, if you have a clinic that's seeing one-on-one patients, can you do this? Absolutely. You're 9-on-1? Dude, there's no way, right? And they all want a quick fix, right? But that's the thing. In the hospital, right, exactly. I mean, how many times in the hospital do we spend 20 minutes just getting to the edge of the bed and sitting there? Could you integrate some of this into that while you're sitting there doing seated balance at the edge of the bed? Yeah, right? That's what's great about this for the inpatient world. I mean, that's fantastic for the inpatient world. You can really integrate this stuff a little bit easier because you have a little bit more time, and they're more of a captive audience. It's not like they can get away from you. Right. It's just, and it's going to take some time, right? We're just not there yet. But when we start tying results to reimbursement, we're going to have to start looking at this more frequently. Any other questions? Any other comments? Thoughts? Did you guys have a good, I heard you guys did something yesterday. It was Dr. Reskin that was in your class. Peripheral sensitization, central sensitization. Is that what you're asking, Alex? So peripheral sensitization, right, is where you experience a trauma. And again, trauma doesn't necessarily mean accident. Trauma can be something as simple as, a shell shock. It can be abuse, right? Any of that can be trauma. And when you get that trauma, you get an abnormal reaction to sensory stimulus. So an abnormal reaction to external peripheral sensory stimulus. So, so say you walk up and you put your hand on the patient's shoulder. Well, putting your hand on the patient's shoulder normally shouldn't do anything, right? They may feel it. They may get the proprioceptive, the kinesiology, the pressure, the baroreception, maybe a little thermoreception if your hand's warm, right? But what the patient experiences at the point, instead of feeling the normal sensations, they get hyperalgesia, they get pain. Right? So peripheral sensitization is where the periphery is responding abnormally, typically with pain, to non-painful stimulus, right? Which is very similar, but not quite, to central sensitization, right? Central sensitization is where you've been jacked up on all these problems for so long that it's where you get those graded potentials that pushes that threshold up. So it takes less and less to trigger off that painful response, right? Where, say with a needle, I stick a needle in your hand. Sticking a needle in your hand is going to hurt, right? But if you have central sensitization, that pain is excruciating. And it's nothing to do with that nerve. It has to do with the way your brain is processing. The central portion of your brain is not processing pain right. The nociception response is way off. Whereas the other one, your normal other sensors, your baroreceptors, your thermoreceptors, kinesioreceptors, all those respond like nociceptors. In central sensitization, your nociceptors report an abnormal signal to the brain, or the brain just doesn't interpret that nociception properly. Does that help clear it up a little bit? It's a really complex topic. But that's why I gave you that one slide, because you're going to run into questions where you're practicing for your boards, and you're going to, I don't remember this, and that's why I put it on one slide for you. Anything else? Any other questions? God, that pimple is horrible. All right, guys. Well, that's it for me for today. I'm going to stop the recording.